Hello, everyone. I'm going to wait a moment to do a quick introduction while everyone is logging in and getting ready to go for our seminar today. Great. It actually looks like everybody was quite quick. Welcome, everybody. My name is Sarah Quist. I'm a client relationship manager with Vision Capital and a partner. I have been here for 21 years. This is one of my most favorite seminars that we do with Willamette Valley Benefits. We all understand Medicare can be very complicated topic, and we're thrilled to have Heidi with us today to go over the subject. If you do have questions, feel free to post them in the chat group and we will continue to monitor those. We may stop throughout the seminar to go ahead and address those questions, or we may wait until the end. But please feel free to use that chat box to ask us questions. And obviously, we will have slides after the presentation as well. And for everyone who may have more questions after the event, you can also reach out to your client relationship manager at Vision Capital. So I will let Heidi take it away right now. And again, thank you all very much for attending.
Hello, everybody. Thank you so much for having me. Thank you, Sarah and Liz, as well. I appreciate it. I am going to go ahead and share my screen so you guys can all see our PowerPoint. Does that show up okay for everybody? Perfect. All right, so I am going to do my best to take a look at the chat as we go through and answer questions. I want to make sure that everybody's kind of on the same page as we go through this, so I will stop here and there. If I miss anything, feel free to reach out at the end. I will have my email and information up there ready to go, so you guys can reach out to me if you need to with any follow-up questions. But we'll go ahead and get started. So here are the parts of Medicare. If you are already on Medicare, you should have a red, white, and blue Medicare card in your wallet or in a safe place at home that has both Medicare Parts A and B on it. If it only has one of the two, that's still okay if you're still working, and we'll get into that a little bit more. But what you get with these parts are Medicare Part A covers your hospital benefits, so brick and mortar facility at the hospital. Part B covers your physicians and lab work, things along those lines. Part C and Part D are something that you actually purchase through private insurance companies. So those are things that you would have to elect to add on to these different parts of Medicare, but this is kind of the base. This is what we're going to be going over today. All right, let's see. All right, so original Medicare. What do we actually get with Medicare Parts A and B? So Medicare Part A, we talked about briefly. It covers the hospital, so brick and mortar facility if you're admitted in an inpatient. One thing that I do want you to keep in mind as we go through these figures is anything in red is subject to change every January 1st. And all of those new amounts will come out usually right around Thanksgiving time. They get posted to the Medicare website and all the information from the insurance companies starts to get updated at that point, but they will change come January. So we're looking at 2025 information here. If you were to stay at a hospital and all you had was Medicare Part A and B, Medicare Part A would cover all but a $1,676 deductible for days 1 through 60. If you stay longer than that, you can see that there's copays that will increase based on the amount of time that you stay in the hospital. Hopefully you never have to utilize that because that's an awful long time, but the benefit is there if you should need it. Medicare Part A also covers skilled nursing facilities. You have to have at least 3 days in the hospital in order to qualify for that benefit with Medicare. The first 20 days are covered at a zero copay to you, and then $209 $9.50 a day for days 21 through 100. If you stay longer than 100 days, doesn't happen very often, but if that's the case for you, there is no coverage after those 100 consecutive days. That's something that would be covered under a long-term care policy, but it's not part of your Medicare benefits. So you do have to be discharged from that facility for at least 60 days in order for that benefit to reset. Now, say you went in or you had a loved one that stayed in the skilled nursing facility for 5 or 10 days or the full 20 days, and then they came out and went back in within that 60-day time frame. What they're going to do is they're going to pick up right where your old benefit left off and continue that 100-day count. So if you only used 20 days the first time around, you were out 59 days and go back in, you're starting at day 21 of that benefit. Home health care is something that your provider would have to write a prescription for, and that is for folks who are needing to have physical therapy, occupational, or speech therapy at their home, and it's a hardship for them to go out to the provider to have those services done, but that is a covered benefit under Medicare Part A, as well as hospice care. The only part of hospice care that a member will pay for is any medications that are related to hospice. So that would be like the liquid morphines that folks get while they're going through that process. That is something that's covered with a $5 copay under Part A. And that's the only medication that's covered under Medicare Part A at all. Medicare Part B is going to cover your physicians. So this is going to be doctors, this is going to be day surgeries, as well as the facility charges are covered under Medicare Part B. You're also going to have things that are like durable medical equipment is covered under Part B, x-rays, physical therapy, trying to think. Durable medical equipment, I think I already said that. Diabetic supplies and monitoring, and infusion medications. So anything that's administered through an IV at a doctor's office, as far as medications go, would be covered under Part B as well. Now, how Part B works is a little bit different. You're not going to have a bunch of copays that you're looking at on this side of your Medicare benefits. You're going to pay a deductible one time per calendar year for whichever benefit that you have first under your Part B services. In 2025, it's $257. And then after that, you will be charged 20% of the cost of those services, and there is no out-of-pocket maximum. So your charges will continue to grow as you have services done, but it will remain at that 20% after your deductible is met. Some of the things that Medicare does not cover are travel outside of the United States. None of those countries bill Medicare, so that's something you'll want to definitely be aware of. There's no coverage for medications that you pick up at your pharmacy. So that is not part of your Medicare A and B benefits. And also no long-term care. So all things that we would have to take a look at outside of Medicare Parts A and B. So the next part of this is kind of seeing where we're at with premiums. How is this going to affect my monthly benefits and the cost for me? So Medicare Part A does not have a premium attached to it as long as you've worked 10 years and paid your Medicare tax. That also will include a spouse. If you've been married to them and they've worked 10 years under and paid their Medicare tax, then you can also claim under their benefits if you don't have that working history. Medicare Part B will be something that you will have a premium for, and that is based off of your income filings from 2 years ago. So when you do go ahead and apply for Medicare Parts A and B, the Social Security Administration, which is where you would go to apply for your Medicare benefits, they will take a look at your tax filings from 2 years ago, and then they will send you a letter. that says, we see that this is what your income was for 2023. So here's where we're going to place you, and here's what your Part B premium will be every single month starting on X date. If you are an individual and you make $106,000 or less for your modified adjusted gross income filings in 2023, then your 2025 premium would be $185 a month. If you are married filing joint, it's $212,000 is the threshold. Now you can also see that these thresholds do increase and the premium will increase. These do change every single year, and it does get reevaluated automatically every single fall. So the Social Security will send you a new letter every fall with what your updated premium will be based on your tax filings for in 2026. It'll be based off of 2024 tax filings. All right, I'm going to pause here for a second and see if I've got anything in the chat box. And I think we're okay. So we'll go ahead and move on to the next slide. All right, so just the same as you had a grid showing what your Part B premium was, if you are somebody who is in these higher income brackets, not only will your Part B be higher, but you will also have a higher Part D, as in dog, income related adjustment. This does not give you any benefits in picking up your prescriptions at all. This is something that you're just really paying more into the system to help cover some of these low income programs that are out there because you made a higher income than the average household size did. Again, it does get reevaluated every single fall, so you will get a letter updating that and putting you in the correct bracket for the next year. All right, so when can you enroll? These questions come up quite a bit, and we do have some pretty open timeframes to start your enrollment. So if you are getting ready to age into Medicare, so you're approaching your 65th birthday, you're a couple months prior, what is your window to enroll? Well, that is called the initial coverage enrollment period, and that is a 7-month window that surrounds your birthday month. So if you are born on the 15th of September, you would have 3 months prior to your birthday month to start your application process for Medicare Parts A and B, and your benefits would begin on the 1st of September. You could apply in the month of September and your benefits would begin the 1st of October, or you would have October, November, December, the 3 months following your September birthday to apply for Medicare benefits to begin, and those start dates would coordinate. So it's always the 1st of the following month that you apply once you've gotten into your birthday month. Typically, we do like to chat with people and make sure that they are applying in those first 3 months so they get their benefits when they're first eligible. So definitely keep an eye on that. Mark your calendar. If you are somebody that has a birthday on the 1st of the month, so if your birthday was September 1st, you actually get the whole month prior to your birthday month to start your Medicare benefits. So instead of starting those benefits September 1st, you would start August 1st. So that kind of kicks your whole enrollment process back a couple months. Annual enrollment period is the next one we would want to talk about, and this applies to everybody that's enrolled in a Medicare Advantage plan. If they want to enroll in a Medicare Advantage plan and they don't have one currently, they're on a different type of coverage, or if they're on a prescription plan. So this is the time frame. You get all those commercials, you hear all these advertisements, mailers, Everybody's trying to earn your business because this is the time frame that you get to look at all of your options that are offered in your area. You get to really dig into the details and decide who you want to enroll with for January 1st coverage. So October 15th through December 7th, you can go ahead and make as many changes as you want to your plan. The last one that you submit on December 7th is the one that starts January 1st. So I don't recommend filling out multiple applications, but you can make changes during that time frame if you need to. The next enrollment period is the open enrollment period. This is kind of something that we've deemed the fix-it period. You don't hear a lot of advertising with this enrollment period because CMS, the Centers for Medicare and Medicaid Services, has some really strict guidelines on what you can and cannot do during this enrollment period. This is built for people who are on a Medicare Advantage plan. And after January 1st, they try to go and see their doctor and they're like, oh my gosh, my doctor doesn't take this plan. Or I thought my medications were covered, but they're really not. I've got a problem and I need to fix this. So during this enrollment period, you have one opportunity to make a change between January 1st and March 31st, and that's the change that sticks for the rest of the year. So once you've made a selection during this time frame, that's it. It's really important to have this for those folks who are coming up against doctor changes or network changes or anything along those lines, but it is a one-time fix-it type of period. Special enrollment periods, these can happen all year long. And these are more situational based. So if we have somebody who, say, lives in Oregon and, their family moves to Arizona or Florida, or they decide they're sick of the rain here, so they're going to go ahead and move somewhere shiny, you can do that. But typically your plan that you bought in Oregon is not going to follow you to that shiny state. It's a whole different list of plans and designs and offerings in that new area. So that gives you a special election within about 60 days that you get to change your plan. So you can do that for moving. You can do that if you qualify or lose your qualifications for Medicaid. If your plan leaves the service area, those are all reasons that you can make a change outside of any of these windows, should you need to. All right, so this is our duplex. I am super visual. It helps me explain things and kind of boil down the options that folks have when they're getting ready to choose a Medicare plan. So what we have here is a duplex kind of platform. We have our foundation, which is Medicare Parts A and B. Those are from the government. You have to have both A and B in order to be able to enroll in any other plan type above and beyond original Medicare. So we have no premium for Part A in most cases, and a premium of at least $185 a month for Part B. That's going to be a constant. Then on the left side of the duplex, we have our Medicare Supplement or Medigap plans. These are typically lettered plans, so you'll hear folks talk about Plan G, Plan K, Plan N. They are all standardized, and Plan G benefits with one company is going to be exactly the same as the Plan G benefits with another company. So it makes it really easy to compare. Those plans, you're looking for customer service, you're shopping for customer service, price, and then if they have extra benefits, some of them may include some extras like a gym membership or something along those lines. But there really isn't much of a network connected with these plans. They run off of what Medicare A and B's fee schedule is. So for example, we talked about the deductibles for Part A. the deductible and 20% for Part B. You can find plans within the Medicare supplement policies that will cover those for you and leave very little to no out-of-pocket cost on those services, but the premium is going to be a lot higher. So these plans are really strong options for folks who maybe have a lot of chronic healthcare needs, or maybe they don't want to be stuck within a network that is based off of where they reside because they snowbird, they travel quite a bit into multiple states. This might be a really good option because there really is no network. It's based off of whether or not the doctor accepts Medicare, and then whether or not those services are Medicare covered and medically necessary. So it makes billing very easy for providers. The other thing to keep in mind is that since Medicare Parts A and B don't cover prescriptions at a pharmacy, we also see a red box that says prescription drug plan. And we're going to have to pick out a standalone prescription drug plan, which just means you're going to have 3 cards that you're dealing with. And that standalone prescription drug plan will be something that you only show to the pharmacy when you go and pick up your maintenance medications. Those premiums can range. Right now, we're seeing them anywhere from $0 a month all the way up to $100. And it really just depends on your medication list and how robust you need that plan to be for the calendar year. Because remember, again, prescription drug plans we review every single year and they can change. All right, so the other side of this lovely duplex is the Medicare Advantage plan. And these plans look a lot more like an employer group plan where things are very much bundled into one package. You still have to have your Medicare Part A and B benefits in order to qualify and purchase one of these plans. However, when you do that, you are going to have everything be billed through that one Medicare Advantage plan. So you're going to be looking at networks. You're going to be looking at copays for services when you go and have them done. A lot of them can have travel networks, so that is absolutely something that we can work with. But they really take over all the billing, and they can include extras like the dental, vision, hearing.
Heidi, we do have a question.
Yes.
So how do people handle living in multiple states in a year, say 6 months in Florida and 6 months in Portland?
That's a great question. So in those cases, they would definitely need to make sure that their plan is going to offer coverage, I would say, in both areas. Because if you're staying that long, typically folks don't want to come back to their service area for follow-up care after an urgent care or emergency care need. Medicare supplement plans work great for that because it does afford quite a bit of flexibility between the two. Some Medicare Advantage plans will offer that, but that is definitely something that you'll want to make sure is part of your plan when you choose one going into these Medicare options. Okay. All right, so there are 2 more things on this slide that I want to cover. One of them is this really fun little arrow that's pointing one way. So it's pointing from the Medicare supplement side to the Medicare Advantage side. And what that means is that when you are brand new to Medicare, you are in what's called a guaranteed issue period to get the Medicare supplement plans without any medical underwriting questions being asked at all. And a lot of times I'll have folks say, hey, do I have to do a physical? What are these medical underwriting questions going to ask? There is no physical. It really is a list of questions that they're going to ask you, and they can ask you based on the last 2 years of medical history or all the way back to 5. They're going to ask you if you have certain conditions, what your medications look like, what doctors are you seeing, have you had anything diagnosed that you haven't had treated, or any services that you haven't had completed in the last couple of years. If you answer yes to any of those questions and you're not in a guaranteed issue period, they can say, no, thank you. We're not going to take you on as a member. That just means you stay in that Medicare Advantage world. We can review and change your plan every single fall with no medical underwriting questions asked at all. If you're in the first 6 months of Medicare Part B enrollment, or if you have a qualifying event, like your plan leaves the area and is no longer offered, you move to another state, your plan is no longer offered, things along those lines, then you would have the opportunity to enroll in these Medicare supplement plans without any medical underwriting questions being asked. So much easier if you're new to Medicare to start on the Medicare supplement plan side if you're considering that option and you think it might be a good fit, and then move to the Advantage side later. A little more difficult to start on the Advantage side and then later in life move to the supplemental side. I'm going to pause and see if there's any questions on that piece. And I have my chat box up now, so I will keep that up. And then while you guys are typing, if you are, the roof of this is the Center for Medicare and Medicaid Services. So what this does is they oversee this whole process. When you submit an application for any of these plan options, they are going to verify that you live in the service area of the plan type that you are applying for, that you have both Medicare A and B, and that you have a valid election period. So you're applying during AEP or you're applying because you moved to a new state, something along those lines. So they oversee all of that. They also make sure you're not living on both sides of the duplex. So this is our oversight program. So if you ever get anything from CMS or the Social Security Administration, make sure that you open those bits of mail. They will always be mail. They will never be phone calls. So please keep that in mind as well. All right, I don't see any questions, so I'm going to go ahead and move on. All right, so this is what our duplex looks like if you had those cards in your wallet. So on the left side, you can see that the Medicare Supplement and Part D plans both have a card separately. And then you also have to have your red, white, and blue Medicare card because we are billing all of our medical benefits through our red, white, and blue Medicare card as the primary insurance, and then our lettered supplemental plan as your secondary to help pick up those deductibles and copays that Medicare left for you to pay. And then we have a separate prescription plan card to use at the pharmacy, or we can go ahead and use just the Medicare Advantage plan, which bundles everything into that one package. We file our red, white, and blue Medicare card away in a safe place because things should not be getting billed through that. If you're on a Medicare Advantage plan, it should just go through that Advantage plan that you chose. Okay, so now we're gonna dig into prescriptions. And this is where we have a lot of changes in the last couple of years. They've been really good. They've had some effects on the market, but honestly, a lot of these changes have been really positive ones for our members and our clients. And so I'm kind of excited to go over this. So these are the federal guidelines for the changes, and all of the plans that offer prescription drug coverage to a Medicare beneficiary, they have to abide by these guidelines. So within the plan itself, you might see variations of this, but this is the minimum threshold. This is what they have to offer at a bare minimum. So any plan that offers drug coverage, they could have a deductible of up to $590 in a calendar year. Some companies have that. Some of them say, I'm only going to charge a $200 deductible on the medications, and then I'll cover them at copays. Some of them say, we're only going to charge a deductible towards higher cost medications, not your regular generics. So you're going to see variations as you go through the plans. Once you've met the deductible, then you get into a copayment or a co-insurance structure. So a copayment, just a flat fee, could be $5, could be $0, could be 47, could be 100. Just kind of depends on where that medication falls within the insurance company and the plan design. And then we have something called an out-of-pocket maximum on these plans now, which we actually never had until last year. So the year before, it was an $8,000 threshold. We are now down to a $2,000 threshold, which means that if your deductible or your copays ever reach $2,000 out of your pocket in a calendar year, then between the insurance companies and the manufacturers, you will be covered at 100% for the rest of the calendar year on your prescription medications only. So you have a cap of $2,000 out of your pocket in a calendar year towards medication costs. Not a lot of people get there. Usually you have to be taking some pretty expensive medications, but it is a good safety net for those folks who fall into that category. Prior authorizations, step therapy, and quantity limits, these are all tools that the insurance companies will use in order to kind of help make sure that you're not taking medications you shouldn't be, which is where the prior authorization comes in. That's really a permission slip. It says, hey, doctor, why do they need this specific medication? It's either a super expensive med and we have generic alternatives, or maybe this is an opioid and you're asking for a higher quantity. Is this something that we should be giving the client? So prior authorization is permission. Step therapy is they're going to ask you to try an alternative on their list of covered medications before they give you, whatever that medication is you're asking for. If you've already tried those alternative medications, your doctor can submit those notes and say, yeah, we've tried those and they don't work. And I do see your question. I'm going to come to that in just a second. And then quantity limits. So quantity limits are something that is really just a safety net for you. So again, we used the opioids earlier. They want to make sure that you're not getting too many of them in order to kind of help curb some of the situations that we've seen in the past. We shouldn't be getting 60 in a month. It should be, maybe 10 to get you through breakthrough pain at the end of a surgery. And then if you need more, we'll write a script for more as needed. So just kind of a controlling measure on quantity for everybody. The last piece before I answer that question is insulins. And this is huge. So insulins are something that in the past, I've seen a ton of clients that would kind of stipend out their insulin medications because they were so expensive and they were unaffordable for a lot of folks. So what has changed there is that insulins, as long as they're on your plan formulary, those covered insulins are not subject to the deductible. They cannot count towards your deductible, and they must be covered at a 35 or better copay for a 30-day supply, which has helped so many people stay healthy. So I'm really excited about that. And the question that we have in the chat, how was this change from 8,000 to 2,000 made? Who made it? Likewise, how was the out-of-pocket cap decided at all, and who made that decision? So great question. Actually, there was no prescription drug coverage until 2006. It was just people had to pay for it on their own. And then what happened is they said, well, this isn't working. People are not taking their medications and they're becoming sicker and having more hospital stays. So they did go ahead and start rolling out prescription drug plans with insurance companies to help cover those costs for members. There was something called the donut hole or the coverage gap. And how that worked is you had coverage up until a certain point, a dollar figure, and it changed every single year. You would have coverage where you would pay copays until between what you spent and what the insurance company spent met a certain threshold. Then at that point, you would have no coverage up until a certain threshold or the coverage gap, and then you would have 100% coverage. And it evolved over the years. The Inflation Reduction Act is what changed all of this. And so that was signed in by the Biden administration, and they went ahead and pushed that through. And it's made some really positive changes in this area for prescription drug coverage. So it used to be that the coverage gap or the donut hole was an $8,000 marker that people had to pay out of their pocket before they would get any more extra help with their medication costs. Now they've flipped it, so there is no coverage gap or donut hole. It is really an out-of-pocket maximum of $2,000 in a calendar year that a member would have to pay before they get 100% coverage. And they get to pay copays and co-insurance amounts during that time frame instead of the whole cost of the medication. So it's been a really great thing for a lot of folks, and made a huge impact in the community. So again, I mentioned that these benefits do change every single year. January 1st, I can let you know the deductible will increase on these prescription plans to $615 for the year. And the out-of-pocket maximum will increase to $2,100. So not anything super drastic or horrible, little bit of an increase and pretty reasonable for what we've seen in the market previously for increases. Oop. All right, so that is the end of my presentation. This is our contact information for our agency. I have been here for 18 years. Willamette Valley Benefits has been around for about 20. And we have about 28 ladies in our office that help Medicare beneficiaries. So if you are somebody that's looking for help walking this path, we're happy to do that for you. If you just are looking for some extra information, you're welcome to reach out to me or and call. I'm Heidi Dulay. Again, I'm happy to help and help you answer those questions. So thank you everybody for your time.
Thank you, Heidi, for the presentation. If you do have questions, this is a complicated topic. Obviously, reach out to your client relationship manager. And we have been working with Heidi and her team for many years. So I have a lot of confidence that they can walk you through the steps as well. So thank you again, everyone. We do have one more question that hopped in.
Yeah.
What happens if I'm still working after the age of 65? And I think that may depend on if you have coverage through your office, but Heidi, I'll let you answer that
Yeah.
question.
Yes. Okay. So I'm going to give you the fast answer on this one. If you are continuing to work past 65 and you are going to be on an active employer group plan, either through your own working experience or a spouse's, as long as there are 20 or more employees actively working, and you are not on an HSA, then I would say enroll in Part A only. It will be secondary to your employer group plan. And then you can, 2 months prior to coming off of that plan, go ahead and reach out. We'll get you the proper forms so you don't have late enrollment penalties with Part B. If it's less than 20 employees That is where you're going to have to be very careful because technically Medicare is the primary insurance in that case, and your employer group plan is secondary. So you will need to get Medicare Parts A and B. If you do that and have an HSA, you can no longer contribute to that HSA and avoid penalties at that point. So it is something that I would say reach out to a professional, talk about your specific situation, and make sure we're covering bases to avoid a penalty in the future. And then I see another question. Is there still Medicare supplemental plan that has no deductible? I think it was called a Plan F. Yes. So that plan has actually been sunsetted. It is only offered to Medicare beneficiaries who had either Part A and or Part B prior to January 1st of 2020. So if you are in that situation and you're coming off of an employer group plan and you have Part A, then you can apply for that. If you are not one of those folks who had Medicare A or B prior to January of 2020, you will not be offered that plan. Your next best option would be Plan G, as in girl.
You call Heidi.
Happy to help.
I will give you Heidi's phone number. Yes, you can. I will give it to you this afternoon.
Please give me a call.
Or it's right there on the screen. Yes.
Yep. Just ask for
Awesome.
Heidi. I'm the only Heidi here.
Perfect. Awesome. Great. I don't see any more questions coming through. And there again, if you have questions after this event, reach out to your client relation advisor. And we actually can use Heidi as our resource too if we can't answer the question for you. So, oh, thank you. We have another one. What happens if you are prescribed a drug that is not on any plan? That's a good one. Yeah.
Great question. So if you are open to taking a look at alternatives, we can provide you a list of those medications. They're separated by class. You can take that to your doctor and talk to them. If that's not going to work and you really need to have that specific medication, you submit something called a formulary exception, and the doctor would write into the insurance company asking for that to be covered for you. And then can you address Med Advantage plan denial rates? So there's been a few things in the Oregonian that have been kind of scary to read. They place a little bit of fear out there regarding Medicare Advantage plans turning down surgeries and procedures and denying these authorizations for clients and members. I can tell you that in our experience, most of them get approved. We don't have a lot that are denied, and we've been working in this industry a long time. Usually, if they do get denied, it's because there was a modifier code that wasn't placed on that authorization. And so it just goes back to the doctor. The doctor puts the notes in, and then it gets pushed through and it's approved. So, I don't put a whole lot of weight on that rumor and fear. We see them go through quite a bit. And if there's an issue, really your agent should be helping you walk that path and getting it fixed if you can't communicate that between the insurance company and the doctor's office. My wife and I registered for Medicare Plan A, Plan B when we turned 65. But have been on employer provided insurance the whole time. Does that mean we are grandfathered in? You would have the opportunity to apply for Plan F when you get ready to come off of that employer sponsored plan. Yes.
Great.
You're welcome.
And perfect. Just checking to make sure, give it another minute to see if any other questions come in.
Yeah.
Yeah, these are great questions. Thank you, everybody.
Very good.
Great. I don't see any typing, so we will end the seminar now. And like I said, we have Heidi at our disposal, and call your client relationship manager. We know it is a very complex topic. So thank you again, Heidi. And thank you
Sarah.
everybody for attending.
Yeah, thank you.
Have a good afternoon.
You too.
Bye-bye.